Today. Dr. Ehrenreich is a graduate of Wesleyan University in Connecticut. He then attended medical school at the University of Maryland School of Medicine, where he was a participant in the combined accelerated program in psychiatry, which some of you may have also participated in. Following that, he joined the residency program here and then the faculty. And for 25 years, he served as the head of the consultation liaison division, where he really expanded the services with lots of specialized care, endocrinology, vocational rehab, HIV, transplant, and he personally has extensive experience in transplant psychiatry. And he has been the program director for the University of Maryland Sheppard Pratt psychiatry residency since 2012, and the chief of education since 2014. So we're really pleased today to have Dr. Ehrenreich and his over 30 years of experience to talk to us a little about a very important topic. I think one's a lot we struggle with, which is improving our feedback to learners and teachers. So with that being said, I'm turning it over to Dr. Ehrenreich. I think, could you just let us know how you want comments and all to go? I'll have a microphone here if you want it, and then we'll have the people online. Thanks.
Right. Thank you very much. So again, I always feel odd in doing this because I am sure that there's more expertise in the audience than I have doing this. So there are all times that I will be asking for people to give me your thoughts. We think we have it working. Well, there'll be some online polls. So if you have your smartphone out, you can scan the QR code and respond. And many of you also were very nice to respond to an online poll that I sent out, and I'll give some of those responses in the talk as well. So I'll get started. And I think I'll get started here. So these are the learning objectives. I'm not going to read them all to you except for the last one. Which is, I hope that when you leave here today, that everyone will commit to implement at least one strategy to improve both the giving and receiving of feedback in your clinical setting. I hear this all the time from residents that they don't get enough feedback. Faculty feel that they do, but I think we can do a better job. Let me see if I can just do this instead. And I'm also upfront with my goals and objectives. These are for me. I really want to help us foster a culture that encourages giving and receiving back routinely. I think if we do it all the time, it won't be as hard to do. I want to tap into your expertise, and I want to get some suggestions from you on how we can do things better. Outline, we'll talk about what feedback is, what are the components of effective feedback models. I'm not going to go into great detail other than talk about one in particular, what difficulties there are in giving and receiving feedback and how we can do better than we're doing. So let me just ask in the audience, how many, by show of hands, how many people have ever attended a talk on how to give feedback? So maybe not quite half. Looks like all the faculty, some residents. Yes. Anybody have important take-home points that they wanted to share from those talks? Nothing, huh? Okay. All right, so we'll see if my talk is any more effective. All right, so here's a online asking you how comfortable you are in giving feedback to trainees. This residents can fill this out because you supervise junior trainees and medical students. This is for everybody. And hopefully this thing is going to work. I see no response. Oh, there we go. All right, great. So it looks like somewhat comfortable lives out, very comfortable. So, oh, you guys don't need this talk. So it looks like somewhat and very comfortable works is winning out. So we'll see. And 11% uncomfortable. Okay. How comfortable are you in receiving feedback from supervisors? Again, I don't need to give this talk, it looks like. So everybody's more comfortable. I know that I'm not the most comfortable in receiving feedback. And we'll talk about, again, giving feedback to supervisors as well. So, all right, well, thank you for your participation. So this was from the online results from the survey that I sent out earlier. So on a 5-point scale, the faculty were asked, how would you rate your ability to give feedback? It's a 4. The residents, though, in rating the quality and the helpfulness of the feedback, it was 3.45. How frequently the faculty think they give feedback, 4.13. The residents, 3.55 of how frequently they think they get it. And then residents respond how comfortable they were giving feedback. They also were above 4. So this is actually consistent with national studies, which is that people say they're comfortable giving feedback, but the receivers of the feedback often say they don't get it, or gets it less often than the people who say they're giving it. This is also a question we asked both faculty and residents. How comfortable are you giving feedback to supervisors? And you can note a marked decrease in the comfort level from residents. It's also a decrease in faculty, although they're a little bit more comfortable in giving feedback to supervisors. So let's talk about very briefly what feedback is. It's a supportive conversation that clarifies the trainee's awareness of their developing competencies, enhances their self-efficacy, challenges them to set objectives for improvement, and facilitates their development of strategies to enable improvement to occur. And Jack Endy, you'll hear his name a lot in this talk, as he kind of gave the seminal paper on giving feedback in medical education, information describing performance intended to guide future performance in that same or related activity. So again, it's reinforcement or correction with an explanation, so that the learner understands what they did right, what they did wrong. It keeps them on course to meet goals. It's always helpful regardless of where they are in terms of comparison to others. And this should be important, true even for our most expert trainees. They also would benefit from feedback, right? It's best if it's given immediately after the performance or shortly thereafter. And if it's done well, the learner doesn't feel judged, enhances their capacity for reflection, and therefore enhances lifelong professional development. Types of feedback. So there's the formative feedback where you're delivering it during the learning experience, ongoing training and performance. It can be formal, informal, it can be verbal or written. And then there's kind of these evaluations, summative feedbacks, like grades. I think those are less important in medical education. It's really much more important to give formative feedback to help people get better while they're working with you. In our program, we have informal feedback, real time, in the moment feedback on the performance on clinical rotations. I always tell the residents, and I don't know if Dr. Robinson is here. I don't quite see him. So I always tell the residents, when Dr. Robinson tells you, I would not write the note this way. I would write I'd write a note this way, the way I want you to write it. That is feedback. He's telling you feedback about the note, even though he doesn't label it as such. So verbal feedback in the context of longitudinal supervision, when your psychotherapy supervision would say, I would have asked that question this way, that is actually feedback, although we don't always highlight it that way. And again, there's the formal feedback that we have. We have that mid-rotation form, which unfortunately does not get filled out as often as it should, to tell the learner how they're doing and what they can work on the remaining part of the rotation. There's the clinical skills verification forms, verifications that people do, the psychiatric interview and presentations that people do, is get formally watching trainees do interviews and present their cases. And obviously the Med Hub, the semi-annual evaluations. And I'm proposing, and I don't know if we have many of our outpatient supervisors here, there was a poster and a paper at the recent ADPERT conference on scheduling quarterly feedback sessions in the outpatient realm. Residents are assigned to outpatient clinics for a full year, and they should be getting ongoing feedback during that time to see how they're doing. Well, clinical setting actually may determine the type of feedback you give, and we'll talk a bit about that. There's the monthly rotations where you're assigned to one supervisor, like in the CL settings on the inpatient units. There's the year-long assignments, again, the outpatient or psychotherapy supervision. And then there's shift work, like in the ER or the psych ER, where you may only be working with that resident for one time. So you might have a different type of approach to feedback in each of these settings. And again, going back to Jack Endy, the importance of feedback. Without feedback, mistakes go uncorrected, good performance is not reinforced, and clinical competence is achieved empirically or not at all. This was an interesting study. They were looking at internal medicine residents, and they did these quarterly questionnaires using PHQ-9s and questionnaires about their training environment. They found actually that low scores on faculty feedback, they scored low on saying, I get timely and appropriate feedback from faculty, correlated with a statistically significant increase in their PHQ-9 scores. Again, it's a correlation, it's not causation, but again, it makes you wonder about the importance of feedback here. And again, I know I'm belaboring the point here, but the rationale for giving feedback, good feedback facilitates growth, skill development, promotes self-reflection, is central for developing expertise and lifelong learning. And in bold, we had LCME here this week that evaluates medical schools. We have ACGM here last week. So they all require this. So we have to be doing this. And again, going back to Endy, the important things to remember about feedback in medical education are that it is necessary, it's valuable, and after a bit of practice and planning, it is not as difficult as one might think. So feedback models. I was taught when I started on faculty, the old sandwich technique, which is you say something positive about the resident or the trainee, what they're doing, you put in some corrective comments in the middle, and then you say something positive at the end. And again, part of this is the faculty are very concerned about hurting residents' feelings and how they're going to take it. Again, going back to my friend Chuck Robinson, Chuck once told me watching me do this, is he said that I sugarcoated the feedback so much that they did not hear the concerns that I was trying to suggest to the resident, because I was so worried about giving them something positive and something at the beginning and the end, and never quite heard something I was concerned about. So that's the old sandwich technique. There's a new sandwich technique, which I'll talk mostly about. And I think all these other things, I didn't realize how many models of feedback there are. It seems like everybody has their own version with their own acronym, and it gets kind of ridiculous after a while. I think they all are basically the ask, tell, ask model, which is what we're going to talk about. The other one, the ADAPT, which is very similar, ask, discuss, ask, and then plan together. And the plan together actually is part of the ask, tell, ask as well. So I think those things we'll talk about. The SFED model, the basic difference there is to make sure you give encouragement, and otherwise it's pretty much the same. And then the other one talks mostly about the relationship. This is really much for a longitudinal experience to make sure you develop that relationship up front, which I think is important in all of this. Does anybody use any other model of feedback or taught any other model of feedback? Does anybody routinely use a model of feedback? Coaching. Could you say more? Right. So coaching them on a particular scenario. Right. Okay, good. All right. So we're going to talk mostly about the ask, tell, ask. And has anybody heard about this before? Most people have or not? Okay, not everybody. Okay, I've always worried that I'm just telling you stuff you already know. Looks like some people know it, but not everybody does. So we'll go through that. All right. So ask. You ask the learner to assess their own performance first. It begins the conversation. It starts as an interactive process, assesses the learner's level of insight and stage of learning. It's less threatening, separates their behavior from their self, promotes reflective practice. What went well, what could have gone better in the patient encounter? And actually, I have to say that in the interview class, I tried to do this. How was that interview for you? How did it go? You're asking people, how are things going? How was that specific interaction with that patient? What went well? What could have gone better? The tell or the adapt model, which says discuss, you tell what you have observed. So you react to their observation. I agree, you really had a good engagement with that patient. You can comment on what their feedback was or what they saw. You give them feedback on their self-assessment, and then you share your impression of both positive behaviors and areas for improvement. And it's really strongly suggested that you use I statements. I observed this, I feel that, it seemed to me that, I thought you. So you're saying what your reaction is to what happened in front of you. You want to be specific and behavioral about the specific performance or the interview or whatever it is that you're responding to. Be descriptive, not evaluative. Acknowledge and reinforce desired behavior. Limit the amount of feedback. You can't give them 5 things to work on. That's too much. You pick 1 or 2 things to talk about. Avoid assumptions and give it in the context of well-defined shared goals. And we're going to come back to goals and the importance of that. And again, ask the end, but you also have to add that plan together, like in the ADAP model. Ask them if they understand the feedback you provided and what strategies for improvement they can think of. Assesses how well they heard what you said. It allows the learner to develop a specific plan for improvement. Does that make sense to you? What could you do differently? Anything in particular that you'd like to work on? What do you think you can do to improve? How can I help? How would you like to move forward? Give your own suggestions and commit to monitoring their improvement together and follow up. Okay, is that pretty clear to everyone? I will make it even clearer because there's a very nice 3-minute video that's out on the web from the Virginia APGAR Academy. So I will play that for you and hopefully that will work. And hopefully this will be very clear to folks. I think this should work. Just let me make sure you can hear it.
Today, we're going to talk about giving feedback.
Not hearing anything.
First, a quick.
Is there a volume that I'm missing?
B1. I'm not picking it up.
I do want to give.
Today, we're going to talk about giving feedback in the clinical setting. First, a quick poll. How many of you think feedback is an important part of your job? How many of you look forward to giving feedback?
Right.
What's the big deal? Just sit your learner down, tell them something positive, then
Right. So the comment was that in the ask section to start off with what went well. So you start off on something positive before you get to what might have been done better, or just ask how that was overall. It's a good point. Bringing in the old sandwich as well.
slide in something negative and then top it all.
All right. Well, it looks like we may not be able to get the
Isn't that how
video.
it's
I can
done?
always send this out to
The
folks, but I was
classic
trying
feedback
to,
sandwich. Healthy, nutritious, delicious.
okay.
Maybe not so much.
So nothing's working there.
Maybe there's a tastier feedback sandwich out there.
Can I go to the web?
But
Would that work,
before
or that
we
wouldn't make a
can find
difference?
it, We'll
Good.
have to answer.
Because my next
one
slide
very
has their
important
link,
question.
so I can just do that.
What is feedback?
You know,
No, it's the next slide. Just get me PowerPoint. I think it'll pop in. My slide that I had open, PowerPoint.
presentation mode.
So I don't know if that'll work. Let's see. I thought it was the next slide. Let's try. Still not gonna work.
Today, we're going to talk about giving feedback in the clinical setting. First, a quick poll.
It's not as good though, is it?
How many of you think feedback is an important part of your job?
Click on that.
How many of you look forward to giving feedback?
Exit out of that.
What's the big deal? Just sit your learner down,
That,
tell them something positive,
there we go. So that's gone.
then slide in something negative, and then top it all.
Showing here now.
Oh,
This is the link to the web,
yeah.
but it wasn't playing through the PowerPoint.
No, now it's not playing for the PowerPoint. No, it was. We tried, but I didn't get the note. We'll skip this. I think we'll just skip it. So
Today, we're going to
Oh.
talk about giving feedback in the clinical setting.
there you go. There.
First, a quick poll. How many of you think feedback is an important part of your job? How many of you look forward to giving feedback? What's the big deal? Just sit your learner down, tell them something positive, then slide in something negative, and then top it all off with something positive.
Oh, did I just stop it?
All off with something positive. Isn't that
I
how
just want
it's
to see
done?
what they're doing. Let me stop this.
The
Okay.
classic
Go back to
feedback
that.
sandwich. Healthy, nutritious, delicious. Maybe not so much.
I really like. how
Maybe
you're,
there's a
you know,
tasty
sticking with
feedback
this.
sandwich out there. But before we
Yes,
can find it, we'll have to answer a very
All right,
important
thank
question.
you. Thank you for the
What is
feedback,
feedback?
Dr. Richardson. It is a very nice,
Isn't that how it's done? The classic feedback sandwich. Healthy,
it's
nutritious,
bizarre.
delicious. Maybe not so much. Maybe there's a tastier feedback sandwich out there. But before we can find it, we'll have to answer a very important question. What is feedback? Come on, it's not rocket science. Well, actually, it is. Consider this. Here's a rocket that's programmed to hit a target. Blast off. Oh, Houston, we have a problem. So what do we tell Mission Control? Well, we want the rocket to stay at the same elevation and travel farther. So in other words, we want to reinforce some behaviors and correct others. Let's blast off again. Bullseye. Now, we don't have rockets. We have learners, and we want them to hit a whole bunch of targets. We need to watch them and make note of what needs correction and what needs reinforcement. But hold on, how do we get that feedback into their systems? Hey, maybe now's a perfect time for that new tastier sandwich. First, ask your learner to think about how they're doing. That engages them and gets a conversation going. It gives you a chance to see if their ideas about how they're doing match up with your impressions. And that gives you a chance to learn about their intentions. No mind reading necessary. Next, tell your learner what you saw. Show that you've heard what they've said and give feedback based on what you saw firsthand. Use non-judgmental words to describe specific behaviors that can be corrected or reinforced. Regulate the quantity, not too much. Last, ask if you got it right. Check to see if your feedback makes sense to your learner. Ask if there are other ways that you can help them to reach their goals. Wrap it all up with a commitment for the future. That's the ask, tell, ask feedback sandwich. Try it. You might find that giving feedback isn't as hard as you think. Now, who's hungry?
I'm not sure where this is playing. Let's see if I can find it. So how do I get it back on the PowerPoint here? Here we go.
Yeah, it's. It's there.
Thank you. All right, sorry for the technical difficulties. So that's the not working. There we go. Any questions or feedback on the Ask Tell Ask model? Does it seem pretty clear to everyone? Yes? Okay. So again, going back to Jack Endy, in terms of what principles are of good feedback, aligns the goal of the teacher and learner, well-timed, based on firsthand observation, regulated in quantity and limited to remedial behavior, phrased in descriptive, non-evaluative language, deals with specific performance, and deals with decisions and actions rather than assumed intention or interpretations. So you also have to set the stage for giving effective feedback, and that goes back to the relationship that's important. So you need to establish a respectful learning environment, establish an educational alliance, and this often takes time at the beginning of the relationship. Easier done on month-long, year-long experiences, maybe a little bit harder in PES, where you may have the one and only time with the resident. It's also good for the faculty member to model reflective and a reflection and willingness to improve, and often asking the learner, tell me how I can be of more help to you. How can I do better in terms of supervising you and help? How can I help you during this shift in PES? How can I help you today or on this particular rotation? So something particular that you need to learn. And again, it's more likely to be accepted if the learner feels that the supervisor is invested in their learning. So again, setting the stage, you also have to establish clear goals. And I don't know, I've passed out to all the faculty expectations. And one of those expectations, you sit down with the residents at the beginning of the rotation and talk about what your goals are and what their goals are for that rotation. Make sure that's clearly communicated, make sure you've heard their concerns or their objectives for that rotation. So I don't know if we have, I'm curious to the faculty, there's people, aside from the CL service, does anybody feel like they have clear objectives and goals for their residents?
To give first day of rotation, then thing and then go on with both with the students and residents. Great. Go on what they expect.
So you start off that way at the beginning of the,
They should be carrying.
right, written down for them too. That's great. Great. I really encourage people to do that. And if there's a rotation that is not doing that, I am happy to work with you on that so that we have that spelled out specifically for the residents. I'm not going to go into great detail, but I will give a shout out to our CL colleagues who have, luckily they have 3 months with residents. So they actually have very specific goals and objectives for each month of the rotation. And my favorite part, which actually does mirror what our mid-rotation form has, is at the very end, which says, based on this feedback, how can we prioritize learning the needed skills you need over the next 2 weeks? This is done in the middle of the month to find out how they're doing and how they can do better for the remaining 2 weeks. And they have one of these for each month of the rotation, expanding and people getting better skills as they move along. And again, it's a wonderful model for people to think about on their rotations. In the online survey that I sent out, there were some examples residents gave me of unhelpful feedback that they have received from supervisors. Good resident, you're doing a great job, got along well with patients and staff. Keep doing what you're doing and you'll be there before you know it. You just have to keep reading. Read more. So what's the problem with those? Why are that feedback unhelpful? Yeah, read what, right? Exactly. Anything else? Too vague. Okay, need to be more specific, right? I mean, it's wonderful to be told you're a good resident, but what did I do that was good? All right, right? What specifically are you talking about? Okay. They did give some examples of helpful feedback that they have received. I have been told specifically what things I can improve, which allow me to implement changes I need to make in a timely and effective manner. Again, you look at that specific, timely, right? Write X, Y, Z differently in your notes to be more concise and clearer. That sounds like Dr. Robinson, but I may be wrong. Feedback that was specific in what I did, demonstration of alternative ways to do it, and discussion of specific ways they differed. This is also something I would keep repeating, but the idea of demonstration, feedback is more likely to be taken if the supervisor models for the learner what they want them to do. And then in the ED, a couple of attendings would give specific positive and negative feedback at the end of each shift. For example, one pointed out a very specific part of the physical exam I needed to work on. I found this useful because it gave me something specific to focus on during my next shift. So much different types of feedback, right? More specific. So again, and I think most educators have heard this before, but goals and feedback should be what they call SMART. And that is specific, measurable, achievable, relevant, and time bound, or there's a target date. You know, by the end of this 1 month rotation, I expect you'll be able to manage the class, you know, a typical patient coming in with schizophrenia with these following medications, or whatever it is, something specific and a time bound. By the end of this month of CL, I expect you to have the basics of writing a CL note down. So something very specific, measurable, achievable within the time frame you have with the resident. Okay. Again, and then improving a skill requires lots of things. Feedback is part of that. The specific goals we talked about, having that to start off with. But then you also have practice, and you also have to have accurate assessments based on direct observation. I mean, how do we know if you're doing a better job interviewing patients if we don't watch you interview patients, right? So focus feedback, and then a willingness to change, which we'll get to that part as well. So direct observation, high face validity. It's ideally the supervisor observes the trainee frequently and in routine clinical practice. So again, it's not a high stakes, you know, CSV. I have to pass 3 of these in order to get, you know, past my my residency. It provides specific structured feedback based on direct observation in real time. And unfortunately, in practice, direct observation with structured feedback rarely occurs. I've asked residents many times, have you had faculty members watch you do a complete interview? And other than the PIPs and CSVs, not so much. And I really think we need to implement that much more, just so that residents get comfortable doing that. So if we all agree that feedback is so important to helping our learners improve and acquire skills, why isn't it done routinely? Any thoughts? Why do we not do it as often as we think we do or we should be doing? What gets in the way? Time consuming. Okay. Anything else? Fear if you give negative feedback to the residents that you will no longer be assigned residents. Okay. I actually have, we have another poll so people can do this. You know, what are the barriers to giving feedback to learners? Rate each on a 5-point scale. Lack of time, fear of damaging rapport with trainees, trainee resistance to feedback, lack of comfort giving feedback, fear of receiving a bad evaluation from the trainee, or other. Lack of time, fear of damaging rapport, other. I can't tell 100% whatever. Okay. You know, it's weird. Does anybody who put other want to say what the other was?
There's often this feeling of like, well, they could have done this thing better. So much work.
It's a concern that they are stressed out and you don't want to add to their burden.
Like maybe this isn't what is important.
Not relevant at the current time. So, okay.
Things is, you- frustrated because it could change. Example, very simple things. Pick a database, medical history, surgical history. Nothing on the file, nothing on the file. Meanwhile, the HLB says hypothyroidism. Give that feedback to numerous people, numerous times. Some of them do it once or twice. They fix the patient. They are doing the same thing.
Right. So the frustration of giving the exact same feedback over and over again and people not responding to that. Okay. So it looks like lack of time, fear of damaging rapport were the top two. Then third, maybe is lack of comfort, and then fourth, trainee resistance. So this is very similar to actually studies that have been out there. So this was actually in Ohio State, and they surveyed 236 supervisors, and their top barriers to giving effective feedback: lack of time, fear of damaging rapport with trainee resistance to feedback, and lack of comfort with feedback delivery. My hope is we're addressing the last bullet today, and maybe we can talk about the others. So lack of time, how can you approach this differently? I do think formal in-person feedback sessions are helpful. It's helpful to schedule them, just to have them in your schedule so that you have it prepared for that. Informal feedback, however, can happen in real time and may only take a couple minutes, right? Again, if you're critiquing the resident's note, you can simply say, I would have written it this way, or you're taking too long for your note. We need to help you be more efficient. Or I think the correct diagnosis is this, and this is the reason why, or a more complete differential might include X, Y, and Z. I agree with your primary diagnosis, but here's another one to think about, and here's why. So again, it's very specific feedback at the time.
Problem is electronic medical records. People are writing each problem, big paragraph, same paragraph from day one. Sometimes you see the spelling mistake. Patient will be started on ECT. Patient already received an ECT.
Right. Yeah. So Dr. Doty is pointing, if those at home, if there's anybody there, pointing out the problems with the EMR and how things keep getting repeated. I also, I've also told this, I know Dr. Reginald did this a lot when he was here, is at the end of rotation, he scheduled the meeting with the resident to sit down. And again, at least if you could do it twice, like the CL folks, the mid-rotation feedback 2 weeks in, sit down, talk with them about what's going. It can be 5 or 10 minutes. You do it, but in a private space, et cetera, and then talk with them. And the written evaluation, there should be no surprises there at the end of the rotation. There should be things you've talked about, so it's not a surprise. Other ideas how we can address the problem of not having enough time. Receiving epic messages about feedback for your notes. I didn't know that you could do that.
It's saved in the EMR.
The answer, they're shaking no, it doesn't get saved, but I know nothing about that. So Dr. Richardson's our epic expert. Okay.
They recorded.
Right. So Dr. Richardson says staff, okay, all right. So then staff messages are not kept in the medical record, but there's a question whether they're discoverable or not.
Can give you a couple of examples or not.
Right.
We were doing it for a while. Patient. That I think is best thing. Patient does it. I generally ask comments from other residents. Most of them are much harder. I say, no, it is not that. It's a good job, but these are things. I found it, I did this way back in New York. Actually, the peers are much harder in deciding.
Okay. So,
Much better.
so the comment is that the peers are harder on giving feedback than the supervisors. Go ahead.
Just to, I think one thing that I struggle with, it ties into the EMR. I would love to be able to sit down and pull their dinner. It takes a long time, and the EMR information. And oftentimes people have so much information in the patient that at night, hard to do that, but I found. I bet a bowl of wine cup every week. I had to like that word style interview with your man. That's 6 months. And that's good. Which is having that practice, even though that's artificial, the real patient. Really only without the distraction of all the other.
Yeah, so again, residents may not know this, but you used to have outside supervisors come in and meet with you on a regular basis. The residents told me they had no time for this. So we pulled that.
So like just taking maybe 30, 40 minutes of our day. In reality, I think the best feedback we get are the minute ones that you present and you're like, hey, I know like when we go talk with a patient, you handle that, laying down the law pretty well, good work, next time try this. That's 90% of our growth. So all observed interviews are great. No, 99% of our these small.
So
Just want to emphasize too that the scheduling aspect of this, 9 times out of 10, it's
So again, to anybody not here remotely, the comment is that the residents are always asking for feedback and the burden seems to be on them to get it done. And again, I'm trying to change that. That's the hope.
Following years, only 2-3 times, resident asked for mid rotation feedback. We are busy, we don't remember if the resident asked.
Right. Okay.
But it never happens.
Well, again, I'm open to suggestions, and if I need to meet with each rotation, I'm happy to talk with people to figure out how to make this happen more frequently.
Taking care of that is higher.
Well, yeah, the medical school has consequences if it doesn't happen. They don't pass the rotation, so. All right, let me just move on for time purposes. In terms of the other common reason for doing this, for not giving feedback is fear of the damaging rapport with the residents. Again, if you can focus at the beginning of the rotation about your investment in the learner, the goals that you want them to obtain. And again, going back to modeling, and I know it's hard, but again, in that expectations I have is that residents should have an opportunity to watch and attending do a complete evaluation. So they have an idea of seeing different people do different things. Then focus on the delivery, like we talked about, the ask, tell, ask, I statements, provide positive feedback and correction with an explanation. So I think, and this group may not feel this way, but I think most of us are not all that comfortable at receiving feedback. And I think it's because we get defensive. We feel like we are being attacked or devalued. And why do we discount the feedback that we're getting? We don't trust the person giving it to us. We assume that or think it's wrong. It's upsetting or confusing. We get inconsistent feedback from different supervisors, so you don't know what to do with that. And it kind of triggers, we all have, that own internal voice that has our own negative self-evaluation, which gets triggered a lot with these things. So I asked again in that online survey about residents' perspectives on difficulties receiving feedback. They feel like the faculty do not understand the context of their work environment, the workload and schedule, particularly during the PGY2 year. Scheduling a time to have a feedback session with attending when both residents and attendings are extremely busy, getting back to the time issue. Inconsistent times, confusing feedback by different attendings. Feedback does not consist of actionable items that can help me improve my performance. Even the instruction of read more is unhelpful. What text would you recommend? And receiving feedback when feeling burned out and vulnerable can be a problem, which we'll talk about if we have time, but we may be running out of time here. Faculty perspectives on why residents have difficulty receiving feedback. That basically the residents take it personally. They feel globally criticized. They feel the feedback's vague, hard to know what to do with it. And that usually we have excellent residents, so any negative feedback feels terrible to them. How many people have ever gone to a talk on how to receive feedback? So the answer is very few, like nobody in here raised their hand. And this is kind of an interesting thing, and I don't have time to go over this video, which I can share with you, but there's a TED Talk by Sheila Heen. And they wrote this book, Doug Stone and Sheila Heen, on thanks for the feedback, the science and art of receiving feedback well, even when it's off base, unfair, poorly delivered, and frankly, you're not in the mood. And they go around and give talks all around the world on difficult conversations. And they say the 100% of the time they're asked to talk about feedback, but that never felt like it really had any tremendous impact. And they felt like, there's always a dyad, and the person who's controlling whether or not the feedback gets in is the receiver. And so this whole talk and this whole book is on how to receive feedback, even if you think it's off base. So I'm not going to go, especially with the problems we had with her talk here. But to give you some highlights, tips for receiving feedback: ask for feedback, be approachable, listen and reserve judgment, take notes, ask questions to clarify, ask for examples, paraphrase and summarize, share your action plan, follow up, and show appreciation for the feedback. So you can summarize it by saying, thank you and tell me more. Thank you for taking the time to give me feedback. Thank you for being interested in my success. Tell me more. What else did you notice? Could you give me more examples? And then if you want to really solicit feedback, simply ask, what is the one thing I could do to improve my interview, my performance, my med management of patients, my supervision of you? What's the one thing that I can do to be of help? And I think I'm going to close it up here. The residents have probably seen this slide already. This is a book for the last lecture, and something he wrote about. This is something you should keep in mind when you're feeling criticized or someone's giving you feedback to help you do better. That when you're screwing up and nobody says anything to you anymore, that means they've given up on you. So people are trying to help you get better. And this is, I don't know we have much time here. We probably don't, but if people have any quick comments on this, I'd be interested. This is a true scenario given by a faculty member to me. A resident in the emergency room had a poor interaction with a patient, coming across as condescending and dismissive of the patient's concerns. This is not the first time such dynamics were reported. When the attending sits down with the resident, the latter jumps in immediately saying, "Is this about that patient? This is really the last thing I need to talk about right now. I am overworked from doing nights. I already know what you're going to say, and I just can't handle this." The resident has a very guarded posture and starts tearing up. How should the attending approach this situation? Any comments? There's nobody in this room, by the way. A psychodynamic approach. What do you? Dr. Miller is not here. He's not here for you to impress him.
I had an interesting situation.
Yeah, I think in this case, obviously, my take on this is feedback at the real time is not going to be helpful. And it's more of support, and trying to support the resident emotionally and say, maybe another time when you come back, we can sit down and talk about what happened here. Because obviously it's not going to get in, right? So, but let me just finish up real quickly. So summary, again, I know this is repetitive. My wife's an educator. She always tells me that repetition is important. So setting the stage for effective feedback, establish a respectful learning environment at the beginning of the rotation, establish clear expectations, communicate learning goals, objectives, the rotation, ask the learner if they have specific goals, prepare for their meeting, organize your thoughts, arrange a private meeting space, base it on direct observation, make feedback timely and regular. Again, label the feedback as feedback. Unfortunately, residents don't hear it as feedback because we haven't labeled it as such. The ask, tell, ask model, SMART goals and feedback. Try to make it part of our culture. Again, I think I've repeated all this stuff already, but modeling the behavior is really helpful. And again, online suggestions, and I'm gonna have another thing for people to fill out some other suggestions you have for us. And I thought this was interesting. That if you don't end your day having learned something, improved something, and you didn't get the most out of your day, that's actually my great grandmother used to say, just to tell me you have to learn one thing every day. And again, I'm not doing my job if I'm not providing constructive feedback for you to be the best doctor. Lastly, people may hear your words, but they feel your attitude. So it's really important in the atmosphere that you provide and give them the feedback. And lastly, we suspect that the best teachers do not necessarily impart more factual information. Facts may be obsolete in a few years, but rather they engender a learning climate that makes learning fun, enjoyable, and exciting. And so lastly, if you have suggestions on how we can improve giving and receiving feedback in our residency program, please scan this and fill it in now or later. Hopefully I'll be able to have access to it. So thank you, and I'm open to any questions or comments that people have. Or any feedback on my current rounds, please.
But I've been here 12 years. Things are passing. I have some tangential, some suggestions like you. Probably there is not enough time. It will be mostly it will be like a
Send me an email.
things don't go well in the evening.
Set up a meeting.
Other comments, suggestions?
Yeah, I think is that some of those. That's helpful, but still honoring their, allowing, allow everyone to bring themselves.
Yeah, so the comment is how to match it perhaps to everybody's individual personality in terms of the feedback. Is that a good summary or not? Yeah, I think that's excellent. I actually think, one of the ways to do it, and again, not that I'm expert at this, but I think one of the ways to do it is sometimes ask the learner, whether it's a medical student or resident, what's the best way for you to receive feedback? What's helpful? Again, asking, how can I be of help? What do you need from me? And people would take things differently. And, some people are fine with just very kind of blunt giving feedback, and other people don't want that. And they want to sit down and let's talk about this at the end of the week or whatever. And again, I know that people are very busy. And when I used to run the CL service, if I had 5 consults to see that day with a resident, I'm not doing an observed interview and I'm not sitting down and doing feedback. We're getting the job done. And I get that. But there was always slow times as well that we could spend more time doing things. And I imagine the same thing is true on the inpatient service. I think it's definitely true in the outpatient world. I think you definitely have the ability, you sit down and do supervision. I mean, you have time then to do that. So I think it depends a little bit in PES. If I was hearing the other night that somebody had 14 people in PES or something like that, there's no way you're going to have a long conversation about feedback when there's 14 people waiting to be seen in PES. So obviously you have to pair it to what's going on. Other comments, suggestions? Feel free to add more into the online thing. All right.
Well, I mean, we all have, especially like your own style and style that's not going to work for Dr. Jody, right? If he's trying to say the same thing. Sometimes I think that's about us, like at least explain, like, I do this because to help explain why. So then you sort of
Right. You're giving an explanation for why you do what you do, recognizing that other people might handle the same situation in a different way, which might be just equally as valid. Right?
Feedback is I only heard my name. I didn't hear it.
She was saying that she might handle something differently than the way you do. That's okay. That's right. Okay. Go ahead. Yeah. So asking the resident why they did what they did before. giving feedback. Why did you start off the interview with the cognitive exam as opposed to doing something else?
That's agree with that. I think in general, adults, from a perspective, you
Right.
know, like more than just things
Sure.
like that.
Okay. So again, I know, oh, go ahead.
Just like really piggyback off. That saying, you know, and everything, you know, fostering support. You know, those moments outside of feedback when you're walking from the CL room to a patient room, or walking just asking, oh, where are you from? Or like, where'd you go to school? Or you have specific interests within psychiatry. I think those conversations are gonna foster that environment where someone is more comfortable. Hey, can you give me feedback about my
Right. Yeah. So getting to know the learner as people. Right. I know we're about out of time. I'm also sorry because I'd hoped to make this like actually an interactive thing where we discuss things and people, but this format is really not all that useful for that. But hopefully we can continue. All of us will be committed to working more on giving and receiving feedback, both to residents and also to supervisors and also to medical students. So thank you all.